we mentioned how these symptoms can overlap and you can end up seeing a lot of different specialists. Are there any common comorbidities that you find that are correlated with systemic mastocytosis?
Yeah, certainly. There's, as we talked about, there's certainly osteoporosis, especially osteoporosis in a younger person without a clear reason. We actually had a patient referred to us because she's completely healthy, but had a bunch of lesions in her bones, which were picked up accidentally on an x-ray. They were x-raying something else because maybe they thought she had a fracture or something like that. And then she had all these funny lesions in her bones. And so that's how she arrived at the diagnosis of systemic mastocytosis and had no other symptoms. But then just what Jessica was talking about, no other symptoms. When you go to explore that, oh yeah, well, I have had an anaphylaxis, or oh, I've had some allergy symptoms, but they were no big deal because people are stoic, right? So it wasn't really no other symptoms. It was just not manifested in a way that that patient complained about this symptom. But certainly that patient also had other symptoms. So very interesting. So osteoporosis early on, I would say a lot of patients are diagnosed or labeled with anxiety disorder. A lot of patients have chronic fatigue. A lot of patients also are diagnosed with things like irritable bowel, as we talked about before they get to the place where, because they don't have food allergies, for example, and they do a biopsy and they don't have celiac disease. And some of them may have gastroesophageal reflux. So irritable bowel is also very common that people get diagnosed with. And certainly chronic idiopathic urticaria, that is something that we see in a lot of patients. 1% of patients have chronic hives, unexplained. We put them on medications, but then they start developing other symptoms. So that's a very common one too, is idiopathic urticaria.
And when you say they start developing other symptoms, are they along the same lines of the symptoms that you mentioned, or are there new symptoms? Let's say if a person has chronic hives and they go untreated, for example, or even if they're treated with histamines, do they usually just stay in the chronic hives, or what are the other symptoms that you're referring to? This
Some
is
patients will stay with chronic hives, but then they'll get a newer rash that looks kind of like a mastocytosis rash, or yes, they will start developing more gastrointestinal symptoms, or now they basically have chronic idiopathic urticaria, but they're starting to have anaphylaxis. And most patients with chronic idiopathic urticaria don't anaphylax. It's not something we typically see. And so then, the picture kind of evolves over time. As with anything in medicine, if you start with one thing, that just because time has changed doesn't mean it's that same thing. So, yeah.
And Jessica, I'm so curious, when it comes to advocacy, what outcomes or improvements do patients most often say matter to them when evaluating whether treatment is working?
I think it's that ability to go out and lead their normal life. I mean, for a lot of patients, they'll say, I just want to be able to go to my kid's basketball game and not worry that if the lady in front of me has a really strong perfume, I'm going to have a terrible reaction that's going to put me in bed for 3 days. They want to be able to have control of the symptoms and a little bit of some predictability. Now, in some ways, it's not necessarily, like we don't have a cure yet. We don't know that we can 100% guarantee that. But with these new treatments that are out, with the over-the-counter things we have on the market, patients can often get a sort of complementary, treatment plan that does allow them to do that, to go out and lead a normal life. But they have to go through these other steps of the process, get through the differential diagnosis and the diagnosis, get on a treatment plan, be open and honest with their physicians, put together a multidisciplinary team, make sure you're telling them about everything that could possibly be a symptom. Remembering too that we all are also people that have other things. So not everything is your mastocytosis. So that's why it's important to talk about these symptoms, because you might be saying oh, well, this is just a masto flare. No, maybe you actually have something else too. So making sure you're really getting to the bottom of your health and talking everything out with your physician, and then keep working on that kind of mix of medications until you get it just right, so that you are able to live a normal life. That's what patients want the most. They want to be able to go to Thanksgiving and take their kids out and do things, and not be so afraid of having a really adverse reaction.
Yeah. That's such a great point. I do like to emphasize as well that, that whole blaming just the mast cell disease, because yes, I mean, patients, just like patients with allergies, develop other things. We develop thyroid disorder. We develop, other rashes, atopic rashes and skin diseases. We develop, hypertension, etc. And so certainly not to just blame mastocytosis. And although it is very important in those patients with indolent systemic mastocytosis or systemic mastocytosis. But I think that the hard part for many patients is that sometimes they don't have enough to necessarily make a diagnosis as yet. The technology is much better, but sometimes there's a little bit of a waiting. And whether that's with autoimmune disease or other diseases that are kind of in the zone, in the smushy zone, where, you don't really have enough for us to make a diagnosis yet. And then we're asking people to be patient, but we'll give patients medications while they're kind of waiting. But I do like to talk about the different buckets of, mast cell disease. So mast cells often are blamed for all sorts of things, but that is because they are the sentinel immune cell that is out there. They're by themselves, they're lonely, they're in the skin, in the gut, in the urinary tract, in the lungs. And then when they see an alarm, that's what they're there for. They're there to trigger the rest of the body to say, hey, there's a problem. Everybody come and help me out. Whether this might be a bacteria or whether this is an insult or a chemical or a problem. And so they basically are the soldiers out in the outpost and they say, help me, come over. And then I'm going to cause inflammatory chemicals to be released. So I'm going to bring my friends in to come help me and bring home the troops. And so that is what they're there for. And so when patients have triggers of mast cells, this could be a variety of things. It doesn't necessarily mean that they have systemic mastocytosis. So I tell people, if you think about the different, 5 buckets of mast cell disorders, the most common one actually is allergy. That is a mast cell activation condition. Allergies are an abnormal response mediated by IgE to foods, to environment, to, kitty cats, peanuts, whatever, other things. And so that is probably the most typical, most common mast cell disease. The second bucket that I like to explain is mast cell activation, which is the largest kind of, unknown bucket because it can be triggered by many things. One of which is a genetic disorder called hereditary alpha-tryptophanemia. Others are basically underlying diseases. I mean, people have lupus and they have smoldering other malignancies. They have other autoimmune diseases. And then those will trigger their mast cells and their mast cells will react and they will come to the allergist thinking that they're having a pseudo-allergic reaction. Even things like, bone problems, fatigue, etc. And those patients have an underlying condition that needs to be explained that's triggering their mast cells. And it's a mast cell activating disease, but it's not systemic mastocytosis and it's not allergy. And of course, these can overlap because so many of us, for example, have allergies. And so I think that's the hardest part is that symptom burden right there, where it's either genetic predisposition or basically it's another disease that's causing the activation of mast cells or it's unknown, that is probably the most challenging to patients to evaluate. And of course, then we go on to the genetic, that we know that's codified systemic mastocytosis, indolent systemic mastocytosis, advanced mastocytosis, and of course the GI involved mastocytosis, and then mast cell cancer, mast cell leukemia. So really, the hardest part is this chunk right here, the beginning chunk, especially if patients have an overlap of allergies. So that's, I think, the toughest part for patients.